Today, we're going to have a little bit of a think about antidiuretic hormone. And this is the major hormone that controls water balance. So this session is going to focus on the disorders caused by too much ADH, so that's SIADH or syndrome of inappropriate ADH secretion, and too little ADH effect, so that is diabetes insipidus. And a recurring theme that I want you to have in your heads through this is that ADH is primarily regulating water and not sodium, and that's quite a common misconception. So we're going to begin this session with looking at normal physiology and the functions of ADH and how its release is controlled before applying it to those two disease states I've just talked about. Because understanding how ADH normally regulates osmolality of the blood makes the biochemical changes and the physiological changes that we see in SIADH and diabetes insipidus much easier to interpret. So first, we're just going to really briefly summarize water balance. And water balance within the body is maintained by controlling two things. One, our water intake. So thirst drives water intake. And our urinary water losses. So obviously we produce or we release water in the urine, and that is necessary to help to remove waste products. But we can reduce water losses in the urine by increasing the amount of antidiuretic hormone that we stimulate to release, because it acts on the kidneys to reabsorb water. Now, these systems are really closely linked, and they usually respond to the same physiological triggers. So they're triggered by an increase in the plasma osmolality. That drives thirst, which gives you more water, which dilutes that osmolality, so dilutes the blood out, and ADH, which reabsorbs water, again, diluting the plasma osmolality to bring it back to normal. But it also are both stimulated by a reduced blood volume. Because if you've got reduced blood volume, you want to maintain that blood volume. So the body prioritizes preservation of circulating volume over the maintenance of normal osmolality during severe dehydration or hemorrhage. And that's because, of course, we need to maintain our blood pressure to deliver blood to our tissues, our brain, our heart, and our lungs in order to actually live. But the key point is maintaining this water balance helps to restore our body water levels to where they should be. Now, antidiuretic hormone, it primarily regulates water, like I said already, and aldosterone regulates sodium. So we're not even going to talk about aldosterone anymore because ADH is what we're focusing on. It's about water regulation. And so antidiuretic hormone is made in the hypothalamus and released from the posterior pituitary on appropriate stimulation. We've already kind of talked what those stimulations are already. There'd be a change in osmolarity and a change in blood volume. So it responds to both of those. But under normal physiological conditions, the kidney effect via those V2 receptors, I've just put those in, mine more for interest than anything else, but the kidney effect is far more important than the vascular effects, which is V1. Because significant vasoconstriction only occurs when ADH concentrations become very high, again, such as during severe hypovolemia, for example. So what's happening in the kidneys is if you have a low ADH, you have very few aquaporin molecules or channels. These are the channels that allow water to be reabsorbed into the blood. And so therefore, if you've got low ADH, you have a large volume of dilute urine, sorry. If you have high ADH, you have lots of aquaporin channels, lots of water reabsorption, so your urine volume becomes smaller and it becomes more concentrated. Nice and simple. So the overall effects of ADH, it helps to regulate plasma osmolarity, and that's what it's doing day to day. It does this by conserving water and reducing the osmolarity as necessary, and by concentrating the urine as necessary. And during hypovolemia, it helps to maintain blood pressure, one, by triggering the V2 receptors, so water reabsorption, and secondly, at higher levels, by triggering the V1 receptors, leading to vasoconstriction, and hence an increase in blood pressure. So plasma osmolarity is the most sensitive physiological regulator of ADH secretion. Hopefully I've made that quite clear already. And small changes in the plasma osmolarity trigger ADH long before clinical significant dehydration can develop. So it is by far a stronger signal. Okay, and that's allowing minute by minute control of body water balance, with the whole goal to restore normal osmolarity through that selective water reabsorption or retention. So if you have an increase in your plasma osmolarity, that is detected by the hypothalamus. You have cells there, and in those cells, they have osmoreceptors that detect a change in the concentration of the overall plasma. So that is detected. That causes the posterior pituitary to release ADH. So the hypothalamus and posterior pituitary communicating with each other through nerve fibers, and they communicate, and that triggers the release of ADH. ADH binds to the V2 receptor, aquaporin channels are inserted into the collecting duct membrane, water is reabsorbed, the decrease in plasma osmolarity is initiated, so we get a drop in plasma osmolarity, and we've got that negative feedback, bringing everything back to where it should be. So it's nice and simple in what's happening. So that's the primary driver or the primary regulator of ADH secretion. But we also have hypovolemia being a driver, okay? Because reduced blood volume is that second major stimulus for ADH. So in severe hypovolemia, it's really important to remember volume preservation becomes far more important than osmolarity regulation. So that helps to explain why ADH secretion in these circumstances can remain high even when plasma osmolarity is already low, okay? So in this case, you have hypovolemia. Okay, this can be for a multitude of reasons. So dehydration, extensive vomiting or diarrhea, hemorrhage, anything that is losing body fluids. That triggers volume receptors, so low volume pressure receptors in the atria and vena cava. They detect those changes and trigger the posterior pituitary to release ADH. That triggers the V2 receptors. We get water reabsorption, helping to restore blood volume. But now we're triggering the V1 receptors as well, causing peripheral vasoconstriction. That's helping to support blood pressure, as is the increase in blood volume that is being driven through water reabsorption in the collecting ducts. So it's clear there are two different triggers working slightly differently, different mechanisms driving them, but overall trying to increase, in this case, support blood pressure, and in the other case, supporting blood volume and osmolarity. So we're just going to have a little bit of a review question for you. So I'd like you to press pause, read through the question, look at the answers, and only one of the answers is correct. So press pause. 72-year-old patient presents to their GP, presumably with severe vomiting and diarrhea. Examination reveals dehydration and hypotension, so low blood pressure. ADH is released as a compensatory mechanism. So a little teaching bit in there for you. Which physiological response is most likely due to this ADH release? So is it A, B, C, or D? Hopefully you have put D. So you get peripheral vasoconstriction through the V1 receptors and increased water reabsorption through the V2 receptors. Remember, this is down to severe dehydration. So you need significant amount of ADH to be released to cause that vasoconstriction, but you're also driving that increased water reabsorption through V2s and the kidney as well. Okay, so we've now looked at an overview of how ADH is actually functioning and how it is regulated. Now we're going to think about the first of the two diseases. So that is syndrome of inappropriate ADH secretion. Okay, and this is fundamentally a disorder of excess water retention. So remember, when the plasma normally, when the plasma osmolarity decreases, less ADH is released because we don't need to absorb more water if the osmolarity is already low. But in SIADH, ADH secretion continues despite potentially having a low plasma osmolarity. And so that is not normal. So as we're having continual ADH secretion, you're getting excess water reabsorption, leading to water retention. And a key finding, therefore, due to that excess ADH and due to that excess water reabsorption and retention, there are various variables that you might measure. Okay, so there are variables from the plasma and in the urine that you might measure. So what I'd like you to do is thinking about SIADH, excess ADH secretion, despite potentially low plasma osmolarity, so it's uncontrolled. What will happen to the plasma sodium concentration, plasma osmolarity, urine osmolarity, and the urine sodium? And then will edema be potentially likely or not? So press pause and think about what will happen in each case. Okay, so first of all, we'll look at the plasma sodium. So the plasma sodium will go down, and that is because we've got dilution of it from the retained water. So, and this obviously then goes on to cause a reduction in the plasma osmolarity. So what you have is a reduced sodium concentration. So you have a dilutional hyponatremia. What happens to the urine osmolarity? Well, of course, you're reabsorbing lots of water, so less water is passing in the urine, so it becomes concentrated. And at the same time, the urine sodium is contributing to that. And we'll talk about why that urine sodium goes up in a second, okay? Because as part of it, there's a diuresis process going on as well. A key feature also is that edema is usually absent in these cases, despite what would be perceived as an increase in blood volume. But is that the case? Well, we'll talk about that in a second. Okay, so it's not quite as clear cut as you may think. Diagnosis also requires normal thyroid and adrenal and renal function. Okay, and that's obvious because in these systems, it can lead to similar symptoms. So if you have diseases of thyroid, adrenal, and renal function, they can potentially lead to similar symptoms. So therefore, you just need to rule them out before thinking about SIADH. But of course, what's happening here? We are having a drop in our plasma osmolarity. And that means we've got the excess water retained and a drop in plasma osmolarity. So water is actually moving into the cells by osmosis. And that makes our brain cells swell. And that's what gives rise to some of the neurological symptoms. And so early symptoms may include things like headache and nausea, so fairly non-generic. As the dilution, if you like, the plasma osmolarity drops, the neurological features start to get worse. You may see cerebral edema, which can lead to confusion, lethargy, seizures, and coma. And finally, thinking about it like this, the neurological features of SIADH are therefore really a consequence of brain swelling secondary to that dilutional hyponatremia, so that low plasma sodium and the low plasma osmolarity. So if ADH seems to be causing water retention, why is edema usually absent? So you can see the table there. That's just the results that were present or that you worked out in the last slide that we looked at. So why is edema usually absent? Well, remember what's happening. At the first stage, you've got excess ADH secretion, despite a low plasma osmolarity. So therefore, we're getting lots of water retention, and that's done in the collecting ducts and the distal tubules of the kidneys. That leads to a slight blood volume increase. We're retaining water, we're diluting the plasma out, so we're getting a dilutional hyponatremia. But that dilutional hyponatremia, and that in particular, that increase in blood volume, means we start to get atrial stretch. And that increased atrial filling stimulates the release of atrial natriuretic peptide. And ANP promotes sodium excretion in the kidneys. And as you're getting that sodium excretion, water is following. So what then happens is you've got a volume excess is reduced. So in essence, it's kind of trying to kind of compensate for the increased blood volume that's happening because of water retention. We're then weeing out lots of sodium and the water is following. So patients usually don't have edema because they are usually euvolemic. So their blood volume is usually about right, but you have got a low plasma sodium. So are patients losing sodium? Well, no. Total body sodium levels might fall slightly, but total body water increases much more, which is what's causing that dilutional hyponatremia. So really, SIADH is best viewed as a disorder of water excess rather than a sodium deficiency. Okay, because remember, you'll see a drop in plasma sodium, but you're not really getting a true sodium depletion. It's about water excess. So we've talked about SIADH, and most causes are actually due to increased ADH secretion, despite that low plasma osmolarity that we've already talked about. So ones that you may or may not remember, you don't have to think about all of these. Okay, so some of this will be relevant for you, though, those of you who are doing medicine or other allied health. For science students, biomedical science, not particularly relevant. You can kind of have it in your head if you want to. So you have, I always kind of think of it as chest and head leading to most likely, and drugs, of course, leading to SIADH. So you can think about small cell lung carcinomas. They lead to ectopic secretion of ADH, so secretion from the wrong place, and therefore you're producing ADH independent of normal physiological control. You have CNS disorders such as head injuries and meningitis, and you're just getting disruption of normal hypothalamic regulation, and you can get ADH released through that way. You've got pulmonary diseases, so such as pneumonia and TB. So again, non-osmotic stimulation of ADH, and then you've got the drugs. So a variety of drugs will increase ADH secretion or enhance that action. But the key point about whatever the actual cause is you get different causes, but the same result: persistent ADH secretion despite a low plasma osmolarity. Okay, so like I said, when I've tended to remember this, it's just, I think, head and chest and then drugs is kind of, and that's kind of what's showing there as the most common causes. So we've done SIADH now, so we've got a little review question for you. I'd like you to read through the review and tell us what else you'd expect to see in this patient. So press pause, have a read, go through the answer. Okay, so a 68-year-old patient with small cell lung carcinoma is found to have a plasma sodium at 118, so that's particularly low, and a plasma osmolarity at 260, which is also low. Which additional findings are most consistent with SIADH? So you need to be thinking, what is now most consistent with the plasma results, thinking about what you would likely see in the urine results. So what's the urine osmolarity likely to be, and what's the urine sodium likely to be? So remember, in SIADH, what you have is you have a low plasma sodium, a low plasma osmolarity. You therefore have the opposite in the urine. So you have a high urine osmolarity and a high urine sodium. So therefore, the most appropriate answer in that little list is C, where you have a urine osmolarity, which is pretty high compared to the others, and you have a urine sodium that is also high. Remember, patients are generally euvolemic, so their blood volume is fairly stable, fairly normal, hence the lack of edema. So we've actually done SIADH now, so that's where we have too much ADH being produced. Now we're going to diabetes insipidus, which is kind of the opposite. So, but remembering this is called diabetes, and it's different to diabetes mellitus. They both cause polyuria, but by completely different mechanisms. In diabetes mellitus, it's excess glucose that is causing osmotic water loss. In diabetes insipidus, its inadequate ADH effect is preventing water conservation. Okay, so in this case, remembering what happens, ADH acts on the kidneys to conserve water. But in diabetes insipidus, either you have ADH levels are decreased, so that might be through a cranial effects or central effects. It has three different terminologies that you might see banded around. So cranial, central, and neurogenic, but it's just what's happening in the head. Or the kidneys may not respond to ADH, and obviously that is nephrogenic diabetes insipidus. And so because they don't have any functioning ADH, whether that's they have it at all or whether it doesn't respond, you get decreased water reabsorption. So therefore, large volumes of urine are produced, and excess water loss therefore goes on to lead to dehydration and thirst. So what are some of the key findings? This is very similar to the slide I gave you for SIADH. I just want you to press pause, look at those variables, and think what will happen to those variables. So the plasma sodium, osmolarity, urine sodium and osmolarity, but also then thinking what will happen to blood pressure and heart rate as consequences. So press pause. Okay, so let's have a little bit of a think about this. So you've got large volumes of urine being produced because the ADH isn't working. So your plasma sodium goes up because you're losing lots of water. Okay, and likewise, you're losing lots of water. The plasma osmolarity will often go up as well. Sometimes patients may remain hydrated only because they drink such large amounts of water. And to put it into context, urine volume can hit 3 to 10 liters per day in severe cases of diabetes insipidus. So that's a lot of drinking while you're trying to maintain that plasma osmolarity in that normal range, which some patients manage to do. Urine osmolarity, of course, that drops. You're weeing out loads and loads and loads of water, so it becomes very dilute, and therefore the urine sodium is also low because you're weeing out loads and loads and loads of water, so it becomes very dilute. What about blood pressure? Well, you're losing significant amount of blood volume, so therefore blood pressure can potentially be reduced depending on the levels of water that is being drunk to compensate for that. Okay, so if they're drinking sufficient amount, then blood pressure will be maintained. But if blood pressure is dropped, then of course heart rate goes up to compensate as well. Those are two things that are variable depending on how much fluid the patient is drinking to try and compensate for the huge water losses. So now we're going to have a little think of the differences between central diabetes insipidus, so that's happening in the head at the level of the hypothalamus and pituitary, versus nephrogenic causes of diabetes insipidus. So just so you know, central often down to head injuries or pituitary or hypothalamic surgery. Nephrogenic can be down to chronic kidney disease, kidneys aren't working, and lithium therapy as well, which affects the release of ADH, the effects of ADH on the kidneys as well. So there are a couple of little common examples in there for you. What I'd like you to do now is just go through neurogenic or central diabetes insipidus, thinking about what's the primary effect, what's the ADH level going to be, and what is the response to desmopressin. Desmopressin is just synthetic antidiuretic hormone if it was given to one of these patients. So what would happen to their urine concentration is what I want you to think about there. So press pause and have a little bit of a think about it. This is just a nice little physiological experiment if you want to think of it like that. Okay, so let's go neurogenic diabetes or central diabetes insipidus, the problems in the head. Okay, so the primary defect is a reduction in ADH secretion. The hypothalamus or pituitary cannot make or secrete the ADH, so its levels drop. So therefore, ADH levels are reduced. What's the response to desmopressin? So if you give someone who cannot make their own ADH, synthetic ADH, what's going to happen to the concentration of the urine? Well, it's going to work. You're giving them a synthetic ADH. The kidneys are working fine, so it improves urine concentration. So in other words, you can start to concentrate your urine better because you can reabsorb water because the drug, the desmopressin, is having the desired effect. What if they've got nephrogenic diabetes insipidus? So what's the primary defect? Well, the problem is obviously the kidneys not responding to the antidiuretic hormone. So what happens to the ADH levels? They're normal or often are actually increased because they're trying to reabsorb water, but the kidneys cannot do it. What's the response to desmopressin? Well, the kidneys aren't working, so therefore the desmopressin is going to have no effect. If ADH isn't working, the desmopressin, which is synthetic ADH, is also not going to work because the kidneys don't work. So this response to desmopressin or synthetic ADH therefore forms the basic of diagnostic testing to kind of compare and distinguish between central diabetes insipidus and nephrogenic diabetes insipidus. So, as we've said, central diabetes insipidus, if you give desmopressin, you get a kidney response and you get a small volume of concentrated urine. So it works, desmopressin works. If they have nephrogenic diabetes insipidus, the desmopressin doesn't work because the kidneys don't work, so you don't get a response, and therefore you continue to have a large volume of dilute urine. So, a review question for you. What I would like you to do is read this question as usual, look through the answers. What do you think the correct answer actually is? Press pause. A 32-year-old patient is referred to the endocrine clinic with a 6-month history of excessive thirst and passing large volumes of urine, including waking several times overnight to drink water and urinate. following a period of supervised water restriction, the plasma osmolality increases. Which findings would be most consistent with central diabetes insipidus? So what we've got here is they have been water restricted. Okay, so they are no longer being given water. So therefore, the plasma osmolarity is increasing, which is most consistent with central diabetes insipidus. So remember, in central diabetes insipidus, ADH level secretion is reduced. Okay, so normally water restriction should stimulate ADH, but the patient cannot appropriately increase that ADH because they can't make it. So therefore, the ADH levels are going to be low after water restriction. So it's either going to be A or it's going to be E. Now, desmopressin replaces the missing hormone, and in central diabetes insipidus, that desmopressin is going to work. So the urine should become more concentrated after administering desmopressin. And the answer for that, obviously, is A. It increases the urine concentration. So ADH levels after water restriction are still low, but with desmopressin, we can now concentrate the urine. We can retain water. So A, that is what you would see in central diabetes insipidus. So we've kind of covered this already. How do we diagnose this polyuria? What's actually happening? So we use water restriction and we use desmopressin. Because remember, we have to try and distinguish between whether it's nephrogenic, or neurodenic or central diabetes insipidus. But we also have to consider another condition which is called primary polydipsia. And this is characterized by excessive water intake, which results in polyuria despite normal ADH physiology. It's usually caused by excessive voluntary water intake, but that's often associated with psychiatric illnesses. So remember, primary polydipsia is included here because excessive water intake can also cause polyuria and can be mistaken for diabetes insipidus. So what's the actual test protocol? Well, first of all, we water restrict. So water restriction tests the ability of the kidneys to release ADH. So in other words, can the patient release ADH? Desmopressin, which is the next step in the test, is saying, can the kidney respond to synthetic ADH? So are the kidneys actually working? So like I said, the test protocol, water restriction is performed first, then desmopressin is administered to assess the response of synthetic ADH. So again, as usual, here's a nice little table for you to have a nice little bit of a think. You've got down the left-hand side, you've got the condition, which is either normal person, so no disease, central diabetes insipidus, nephrogenic diabetes insipidus, or primary polydipsia. And on the top bit, you've got what is the ADH level after water restriction, and what is then the response to desmopressin. So what happens to the urine concentrating ability? So again, think what happens under normal conditions if we restrict you and then give you desmopressin compared to central, nephrogenic DI, and primary polydipsia. So press pause, have a good think. So in a nice, normal, healthy individual, if you water restrict, ADH level increases appropriately during water restriction because it helps to conserve water and concentrate the urine. As the kidneys are already responding normally to endogenous ADH, so the stuff that we make naturally, desmopressin produces little additional effect, hence you don't get much of a change there. Then we look at central diabetes insipidus. And in central diabetes insipidus, water restriction fails to produce an adequate response in ADH because secretion impaired, so it stays low. Desmopressin is replacing this missing hormone, which results in a marked increase in the urine concentrating ability of the kidneys. So you'd see an increase in the urine concentration or osmolarity. Nephrogenic diabetes insipidus. Water stimulation or water deprivation rather stimulates ADH release normally, so that becomes high. However, the kidneys are resistant to ADH. They cannot function. to restore that water balance. Therefore, urine concentration does not improve despite that desmopressin activity or administration rather. Primary polydipsia. Okay, so in this case, excessive water intake suppresses ADH release, resulting in low to normal ADH levels. Following water restriction, ADH recovers. Hence, we have low normal levels, because remember, it's normally quite low, and then it starts to come back down to, comes back to normal levels. Following desmopressin, there's little additional effect because the ADH that is being made naturally is doing the work already. So really, normal and primary polydipsia, you can see them, they might be high normal and low normal, but in essence, they're both fairly normal because the physiology is working absolutely fine. So a summary of that, central diabetes insipidus responds to desmopressin administration, nephrogenic diabetes insipidus does not. So what happens during a water deprivation test? So we're forgetting completely about desmopressin now, okay? So we are just going to deprive people of water or deprive patients of water. So on the left-hand side, you can see what happens in normal, healthy individuals and those in primary polydipsia. And on the right-hand side, you can see diabetes insipidus. You can also see right in the top right, urine volume is going to be purple, urine osmolarity is going to be green, and plasma osmolarity is going to be red. So what happens under normal circumstances if you deprive someone of water? Well, obviously, you deprive them of water, so their urine volume goes down. They're trying to retain water. They're producing ADH, so urine volume drops. Their urine osmolarity goes up because there's less water in the urine, so it becomes more concentrate. But the plasma osmolarity should stay fairly stable, okay? In diabetes insipidus, when you deprive water, what happens? The urine volume stays fairly standard, okay? It stays high, but you might be depriving water, but the ADH either isn't functioning or isn't being released, so they continue to produce large volumes of urine. The urine osmolarity also remains dilute because you're just passing lots of fluid, lots of water out in your urine, but the plasma osmolarity will start to go up because they are no longer able to make that balancing act drink sufficiently to compensate. So the plasma osmolarity will go up. So failure to concentrate urine during water restriction is the hallmark of diabetes insipidus. And that's what we showed on the right-hand side graph above. The response to desmopressin, which we haven't shown here, then distinguishes central from nephrogenic diabetes insipidus. So finally, this is the final little review question, giving you something to interpret. So covering this whole session that we've talked about. So covering the whole of SIADH, normal physiology, and diabetes insipidus. I'd like you to read the review question, look at the results, interpret the results, and tell me what you think the most likely diagnosis is. So please press pause. So a 28-year-old patient is referred to an endocrine clinic with a 6-month history of excessive thirst and passing large volumes of urine. So first of all, we're going to have a look at the baseline values. So what we can see there is the baseline plasma osmolarity is slightly elevated, but that's despite unrestricted access to water. So this suggests the patient is just about compensating for ongoing free water losses, which you can see through the large volumes of urine being passed, but also the very dilute urine osmolarity. So it's very dilute, near the bottom end of that 50 to 1200 milliosmoles per kilogram, what the kidneys can generate. Then we deprive them of water. And what we see now is we see the expected rise in plasma osmolarity, but the urine remains inappropriately dilute. It's still very, very dilute. So this is confirming an inability to conserve water. So that's telling us that it is diabetes insipidus. So what we now need to know is it central diabetes insipidus or is it nephrogenic diabetes insipidus? And so we give desmopressin, and the effects of desmopressin are there for you, and it produces only a minimal increase in the urine osmolarity, and also very little change in the plasma osmolality as well. This indicates that the ADH is present, but it is not working because we've given desmopressin, the urine hasn't become concentrated, and the osmolarity has not returned back to normal. So therefore, the overall pattern is one most consistent with nephrogenic diabetes insipidus, which is option C, which is hopefully what you thought the answer was.